Now we'll be quickly going through each specific type of arthritis. We'll be discussing them under these broad headings for the sake of uniformity. A for articular, where we'll be discussing whether there are erosions or not, and if they are present, what is the type of erosion, whether they are marginal or subchondral or central. B for bones, we'll be discussing whether the bone density is normal, whether there is juxta-articular osteopenia, and if there is excessive bony proliferation changes, and if so, whether there are osteophytes or syndesmophytes, chondrocalcinosis, subchondral sclerosis, or enthesophytes. C for cartilage, we'll be discussing whether there is joint space narrowing or not. D for distribution. E for certain extra findings or clinical clues that will help us reach the diagnosis. And S for soft tissue findings. So let's come to the first arthritis, which is osteoarthritis. In osteoarthritis, there are no bony erosions, no osteopenia. There are osteophytes present and subchondral sclerosis that is present. Like we discussed before, it is a non-uniform joint space narrowing. In certain types, you can see subchondral cysts, and these are called geodes. Now in this X-ray, we can see that there is dense sclerosis of the first metacarpophalangeal joint along with severe joint space narrowing. Now wherever you see sclerosis in any joint or any arthritis for that matter, it usually indicates that it is a chronic process that's going on and it's been there for a very long time. That's when sclerosis develops over a period of time. So the distribution in osteoarthritis is the first metacarpophalangeal joint, the PIP as well as the DIP. As far as soft tissue involvement is concerned, we have Heberdin's nodes in the DIP, Bouchard's nodes in the PIP. Next we move on to rheumatoid arthritis. In rheumatoid arthritis, you can clearly see the density of the bone across the joint space is reduced. So there is juxta-articular or periarticular osteopenia. Apart from that, you can see that there are small marginal erosions. Now these erosions are present in an area that's away from the articular cartilage of the joint, right? So these areas are called bare areas because they are not covered by the articular cartilage, but they still belong to the part of the joint which is covered by synovium. Right, so these marginal erosions are a hallmark of rheumatoid arthritis present in the early stage of the disease. There is no extra bony production in the active phase of the disease, and there is uniform joint space narrowing. So the metacarpophalangeal joints, the proximal interphalangeal joints are most commonly involved. Apart from that, the carpals are also involved. The shoulder, elbow, hip and knee joint are also involved. Now one characteristic joint involvement in rheumatoid arthritis that we must focus on is the cervical spine involvement. Here, an important measurement that we usually take is the atlantodental interval. The dens is a part of the axis. The atlantodental interval is usually 3 mm or less, but in rheumatoid arthritis, this interval increases because of atlantoaxial ligament laxity. Now, as a result of that, what usually happens is the dens or the odontoid process of C2 does not stay in its place. So it ends up moving into the foramen magnum. This phenomenon is actually called basilar invagination. So you can see here the dens is actually supposed to lie over here. So this is a clivus, this is the occipital bone. It has actually translated up into the space of the foramen magnum. This foramen magnum is usually supposed to be occupied by the brainstem and the cervical cord. But now this dens is occupying a lot of the space, leaving very less space for the cervical cord over there. So what is going to happen as a result is going to be cord compression. So this particular manifestation can present as anything from chronic headaches to neck pain to focal neurological deficits, and it can also lead to paraplegia. So as far as the soft tissue involvement for rheumatoid arthritis is concerned, it can present as fusiform swellings, and there can be subcutaneous nodules. An interesting thing about subcutaneous nodules is that when there is presence of subcutaneous nodules, the bony joint is usually spared. Of course, there are presence of bony deformities associated with rheumatoid arthritis. So next we move on to erosive osteoarthropathy. This is a generalized form of erosive osteoarthritis which is seen in postmenopausal women. Now here you have subchondral as well as central erosions. So along with these subchondral erosions, you have overhanging bony margins. Central subchondral erosions along with overhanging bony margins gives rise to a gull wing or a seagull appearance. This is also described in certain other osteoarthropathies, but it is very characteristic of erosive osteoarthritis. Apart from that, there can be ankylosis of the interphalangeal joint also, where this entire joint is fused. Of course, you can see that there is uniform joint space narrowing. The distribution of joints is same as osteoarthritis, except the interphalangeal joints are usually more involved, with the DIP being more involved than the PIP. Apart from this, as far as the soft tissue is concerned, there is intra-articular proliferation of the synovial tissue, and there are few subcutaneous swellings. So the next type of arthritis that we move on to is septic arthritis. Now this is a case where there was a soft tissue calcification in the rotator cuff tendons. Now after this, the patient had some kind of shoulder instability and pain. So for that he was given intra-articular corticosteroid injection. A month later, this is the status of the joint. What is happening here is that there are multiple marginal erosions of the humeral head along with subchondral erosions as well. The entire humeral head has become deformed and it has become flattened along with juxta-articular obvious osteopenia. So this is what happens in septic arthritis. Like we discussed earlier, it is a monoarthropathy. Whenever you have a single joint that's being involved, like in this case, the proximal interphalangeal joint is involved along with some soft tissue swelling, but there are multiple erosions. So, but it's the only single joint that is involved. So when you have a monoarthritis, you should always think of septic arthritis first, of course, in relation with the clinical scenario. There are multiple marginal erosions present in septic arthritis, joint effusion along with thickened synovium. There is juxta-articular osteopenia as well, symmetric joint space narrowing. The knees are more commonly involved in adults. The knees and hips are involved in the children. Apart from that, in the soft tissue, you have synovial microabscesses present. So next, we're going to move on to the seronegative spondyloarthropathies. The first one we're going to be discussing is ankylosing spondylitis. The hallmark, or rather the hallmarks of the ankylosing spondylitis group is enthesitis, syndesmophytes, and sacroiliitis. So what do these actually mean? Let's take up enthesitis first. So enthesis essentially means the attachment of the fibrous capsule or the tendinous insertions or the ligaments to the bone. So this is essentially a soft tissue. So the first modality to pick it up would be an MR. We're not going to discuss the MR findings, but once this enthesitis sets in, what happens to the bone? So these are the bony attachments. These are the bony attachments of the enthesis. So what is actually happening here is the anterosuperior, anteroinferior corners, anterosuperior and anteroinferior corners of the vertebral bodies are becoming sclerosed. This white area is the bony sclerosis. So this is called as a shiny corner sign or Romanus lesions, which is one of the early features of spondyloarthropathy, specifically ankylosing spondylitis. So apart from this, we have syndesmophytes. Now syndesmophytes are nothing but the ossification of the paraspinal ligaments. Either it can be ALL or it can be PLL or it can be the interspinous ligaments. So this must be differentiated from osteophytes or spondylophytes. Osteophytes in the spine are called spondylophytes. Here you can see that these osteophytes are oriented perpendicular to the long axis of the spine. There is a horizontal orientation in the osteophyte or the spondylophyte, but here you can see this linear ossification which is along the or parallel to the long axis of the spine. So this is called a syndesmophyte, and syndesmophyte is the one that is seen in ankylosing spondylitis. Apart from syndesmophytes, in this radiograph you can see intradiscal calcifications also. Anyway, so when these syndesmophytes grow towards each other, they fuse, they give a fused appearance of the entire spine, which is termed as bamboo spine. Now this bamboo spine results in a very rigid vertebral column, which can result in severe fractures with even trivial trauma. The spine breaks off at one point, and that's called a carrot stick fracture, leads to devastating complications. So here you can see that bamboo spine appearance. Another type of calcification is this continuous osseous band that you can see of the interspinous ligament. This is called a dagger spine appearance. Now here you can see the discrete spinous processes that have no ossification between them, but here there is continuous flowing ossification. That's called dagger spine appearance. Now the third and most important thing, or rather the earliest feature of ankylosing spondylitis, is sacroiliitis. There are certain interesting things about the SI joint that we need to remember. Now the SI joint has two different parts. The proximal 1/3 is composed of a fibrocartilage. It is a syndesmosis essentially, and the lower 2/3 is lined by articular cartilage. Now in this lower 2/3, the lower 1/3 is only lined by synovium. Only the lower 1/3 of the SI joint is lined by synovium. So what is the significance of this? When the changes of spondyloarthropathy starts, it is the lower 1/3 of the SI joint that is involved, and it is the iliac surface that is first involved, right? So of course later on in the disease there can be calcification within the syndesmosis, there can be calcification within the articular cartilage, but initially it is the lower 1/3 that is involved because that is the part that is covered by synovium, right? So this sacroiliitis can actually be graded. There is a New York grading system on radiographs. Initially what happens is the joint space is actually widened, and then what happens is there is narrowing of the joint space, and then finally it completely fuses. Now this is a normal SI joint. There is a good joint space. You can see the joint space nicely bilaterally. This is a case of complete bony fusion of the SI joints. You cannot see the joint spaces at all, and there is complete sclerosis. Apart from that, before this sclerosis forms, you can see some subchondral erosions and subchondral cysts, especially along the iliac surface and along the lower third of the bilateral SI joints. So that was about ankylosing spondylitis. Next we move on to psoriatic arthritis. Now this is a Moll and Wright classification system for psoriatic arthritis, which is given in certain medicine textbooks, so you can go through that. In the early phase of psoriatic arthritis, you can have small marginal erosions, but as the disease progresses, the bony margins appear overhanging, giving rise to a penicillin cup deformity. Now, this is a flared metaphysis. This is the cup. Yeah, this picture shows a more advanced form of psoriatic osteoarthropathy. So here you can see the tipped cup, the tipped point of the pencil, and this is the flared metaphysis giving rise to that cup appearance. Apart from that penicillin cup deformity, you can also have acroosteolysis, and you can have irregular periosteal reaction, also called fluffy periostitis sometimes. Of course, there is symmetric joint space narrowing. The joints that are involved are usually PIP and DIP. The metacarpophalangeal joints are usually uninvolved in contrast to rheumatoid arthritis. Apart from that, you have multiple skin lesions in psoriasis, of course, and you have characteristic telescoping of fingers. As far as the soft tissue is concerned, you have enthesitis, dactylitis, giving rise to sausage digit appearance, and onycholysis. So that was about psoriatic arthritis. Now next we move on to reactive arthritis. Reactive arthritis is essentially a diagnosis of exclusion. We only think of it when there is a definite history of preceding infection. Typically we read Campylobacter jejuni. Now in the late phase of the disease, you can have ill-defined erosions. But one specific feature is that the calcaneum is most commonly involved in reactive arthritis. There is juxtaarticular osteopenia, enthesitis, as well as bony proliferation. Symmetric joint space narrowing is there. And it is the first metatarsomphalangeal and interphalangeal joints that are more commonly involved, along with the calcaneum, of course. In reactive arthritis, there is soft tissue swelling, and this also can manifest as sausage digits sometimes. So the next entity that we're going to be discussing is DISH, or diffuse idiopathic skeletal hyperostosis, also called as Forestier's disease. Now here, this is one particular condition that must be distinguished from ankylosing spondylitis, Because like we discussed, even in ankylosing spondylitis, you have calcification along the paraspinal ligaments or the anterior longitudinal ligament. In dish, it is specifically the anterior longitudinal ligament and more towards the right side. However, this calcification, like you see, is quite bulky, it is flowing and it is florid. That is the characteristic description that's given, flowing florid calcification between 4 or more contiguous vertebrae, right? So there are no bony erosions in this disease. The disc height is preserved and it is more commonly seen in the lower thoracic vertebrae. Of course, just like ankylosing spondylitis, this condition is also prone to multiple fractures even after trivial trauma. However, there are no obvious soft tissue changes in this condition. So the next arthritis that we're going to be discussing is gout. In gout, you have punched out erosions which are more than 5 mm in size. This disease spares part of the joint space and the overhanging edges of the bone are called rat bite erosions. In the sense, you have these marginal erosions that are quite larger than what you see in rheumatoid arthritis, and you have these overhanging bony margins. In rheumatoid arthritis, there is no bony proliferation in the active phase, whereas in gout, you have significant bony proliferation giving rise to these rat bite or mouse ear appearance, whatever you want to call them. There is preservation of the joint space predominantly. Apart from that, there might be chondrocalcinosis, deposition of calcium within the cartilage. Joint effusion, in fact, is the earliest sign of gout, and as we can see here, the first metatarsophalangeal joint is most commonly involved. The PIP and DIP may also be involved, and it is in usually a random distribution, but the first metatarsophalangeal joint is usually commonly involved, seen in males with hyperuricemia. In the soft tissue, very important, you have eccentric nodular calcification or nodular soft tissue swelling, and this is because of the crystal deposition, urate crystal deposition. Here you can see that there is no obvious bony erosion. The joint space is also well preserved, but in the soft tissue there is faint calcification, and this is a case of tophaceous gout. These were the deposition of the urate crystals or tophi. Apart from this, in the soft tissue you can have olecranon as well as prepatellar bursitis. Now, in certain cases, such as this one, where there are extensive marginal erosions, extensive bony erosions, extensive soft tissue calcification, and you have a diagnostic dilemma as to whether to call this gouty arthritis or some other erosive osteoarthropathy, or if it is in fact a bone tumor, then we can take the help of a modality called dual energy CT. Now, what this does is it shows us these artifacts which appear green in color, or you can change the color as to whatever you want, but this signifies the deposition of the urate crystals and can help us reach the diagnosis of gout. So the next entity that we're going to be discussing is calcium pyrophosphate deposition disease, also called pseudo-gout. Now, a lot of texts call it as chondrocalcinosis, and I mean it is called chondrocalcinosis interchangeably, but then although chondrocalcinosis is the hallmark of this disease, it is very common. Chondrocalcinosis as a finding per se can be seen in other conditions also. So we generally call it pseudo-gout or CPPD. There are no erosions here. Sometimes there might be subchondral cysts. There is symmetric joint space narrowing. These arrows point to the deposition of calcium within the cartilage. Typically, the carpo-metacarpal joints are involved. The triangular fibrocartilaginous complex is involved, which is seen in the ulnar aspect of the wrist. Apart from that, the elbow and the ankle can also be involved, and of course, the most common joint that is involved is the knee. The next disease that we're going to be discussing is scleroderma. So here we have multiple erosions, penicillin cup deformity. There is typical acro-osteolysis seen in scleroderma. Apart from that, there is symmetric joint space narrowing. Interphalangeal joints are commonly involved, and there is nodular and punctate soft tissue calcification that are seen. It can also lead to acral soft tissue necrosis, which is called as mechanic's hand. So this is the typical acro-osteolysis that you can see in all the distal you can see in the phalanges, distal phalanges. The next entity is SLE. In SLE, there are no bony erosions. The joint space is absolutely normal. There's no narrowing. However, you have significant periarticular osteopenia. The bone density is definitely reduced. So this can result in avascular necrosis also. Normally, the joints that are involved are the shoulder, hip, ankle, PIP and DIP, and first metacarpophalangeal joint. Usually there is a symmetric involvement. Of course, there can be deformities and soft tissue calcifications as well. So the last entity that we're going to discuss is sarcoid arthritis. A typical bony erosions that have been described as lace-like erosions are seen. You can also call them moth-eaten, permeative or lytic. The joint space is usually preserved, and of course it is a symmetric arthritis. As far as the soft tissue is concerned, you can have dactylitis as well as myopathy.